Well, the United Nations Children's Agency, UNICEF, has released its global statistical update on HIV and AIDS for children, adolescents and pregnant women. For more on this, we're now joined by Dr. Chewe Luo, who is the Associate Director and Chief of HIV and AIDS Unit at UNICEF. A very good afternoon to you, Doctor. Thanks very much for availing yourself to SABC News this afternoon.
Thank you.
Doctor, briefly talk to us then about how the COVID-19 pandemic has affected HIV services for children, adolescents and pregnant mothers worldwide. I can imagine that, most of the resources and all of the personnel and everything really is so focused on coronavirus and COVID-19 that we've created bigger gaps elsewhere.
Yeah, I think this is an important question, just to say that we've been working hard to make sure that, at every point of care where pregnant women and children access services in many of the countries that we work in, we've been really focused on making sure that they have access to PMTCT services. And in many instances, it's about making sure they have access to HIV testing and also the life-saving medications that they need. But with COVID-19, what we saw in the early part of 2020 was that with the lockdowns that were going on in most of the countries, the fact that health workers were deployed to respond to this emergency, and then the fear that people had within communities on whether to access services at all because they were worried about COVID, meant that for children particularly, we saw a major decline, up to 50%, of HIV testing in kids. And our recommendation is that children that are exposed to HIV, because their parents are living with HIV, should be tested at about 6 to 8 weeks. Then when they come in for their immunization. We saw declines in that. And then because of that, we also saw major declines in access to treatment. And we know for kids, this is not anywhere acceptable, because we know 30% of children, if they're not treated early enough, will die by year 1, and 50% will die by year 2. The good news, though, is that with the community-led responses that we've mounted for a very long time for HIV, and the fact that we have the communication links with populations living with HIV, they were able to organize themselves very quickly around messaging, around supporting each other to make sure that the access issue was dealt with. We're able to communicate with them on SMS platforms to make sure that we're getting them the information that they need, and also to make sure that within the national responses, the people living with HIV were also included, to make sure that the population of people with HIV and their issues could be addressed.
Yeah.
So we saw a rebound within 3-4 months, rebound in the testing rates and also the treatment rates. The worry is that they did not go back to where we were before. And so the issues around access that we had even before COVID were aggravated by the COVID response.
Yeah. Doctor, that's very interesting to me that you mentioned that, there's been this rebound in testing rates. And of course, that then also speaks to access to HIV testing. Doctor, I'm of the view that if you are going to be testing for COVID-19, coronavirus, you already have the personnel, the medical, the medical people there in any case to do certain tests. Why can't we just do it all at once? Why can't a facility that's offering testing for COVID-19, for coronavirus, then also on the back of it, also be able to treat, well, not treat, but to test for HIV and AIDS? Surely you'd then be killing 2 birds with 1 stone if you were able to do that. Why is that not possible?
No, this is an excellent point and an excellent analysis of the situation. In fact, what I want to say up front is that the capacity that we've built in laboratories in advancing testing to people right down to community level has been really instrumental in us moving quickly with COVID testing, because it's the same infrastructure and capacity and reliability that the quality of testing that we've put forward for HIV that has helped us. And country after country, the people that are at the forefront of the HIV response and that are involved in the laboratory and setting up public health standards for testing are the same people that we've drawn upon to actually conduct the COVID test. I think the issue for us is that COVID hit us so hard and so quickly that some of the responses around how do we align and integrate efforts were not done in an optimal way. But what I want to say is that the good news is that as we've been doing this, we've also been working with industry to make sure that we think about multiplexing or multi-purpose platforms for infectious diseases to make sure that we can do this effectively. I think the two pandemics have taught us that we really need in Africa very strong public health institutes, but we also need quality labs to be able to respond to infections like HIV and COVID.
And you know, we've shown that we're able to respond. I mean, even just the fact that our scientists are able to identify new variants, for example. So, and certainly we are ahead, even in terms of where we are in HIV and AIDS research. And so I wonder, you know, the COVID-19 pandemic, you know, it seems quite relentless, Doctor. What more can governments do? I mean, certainly governments and scientists are doing all that they can to fight the scourge of HIV and AIDS, especially with regards to young children, young people, and pregnant women. Is there more that can be done at this point?
Yes, I do think we've learned a lot. And if I think our report from UNICEF actually is pointing to that fact. We're nowhere near where we were in 2000 or 2010. Yeah. We've really learned some hard lessons. And what we're really talking about is how do we continue to improve performance of our programs. And one of the things that we put out in the report is the importance of data, because the demographics for HIV have changed. I'll just give you an example. Yeah. In a country like South Africa, over 95% of women who are pregnant today in South Africa have access to life-saving antiretroviral treatment for their own health, but also to reduce mother-to-child transmission of HIV. What that means is that if you go in any clinic in South Africa and try to find the children that are falling through the cracks and getting HIV, you're not going to find the positive children in those clinics where we're doing well with PMTCT. So the value of understanding your epidemic and your response, and where are the pockets in South Africa where we're not doing well, where we need to ramp up the response to prevention of mother-to-child transmission, but also find the children that are missing through the cracks because mother either didn't get treatment or they fell out of care because we have poor quality services. So that's where we think the value is going to be. And then when it comes to children, we also know that right now, most of the mortality is still in the children under 5, but we also know that most of the infection now is in the older age group, and a lot of those children would have missed HIV testing, either because the mother got infected during breastfeeding, and these kids do perform very different from the kids that are infected when the mother is pregnant, and they're walking around with HIV without us knowing, only to end up in clinics with either tuberculosis or malnutrition. But we're also saying that this is a family-centered disease, and to do better to finding the children and linking them to care, we really need to work with communities, including communities of people living with HIV, to transform this response to a family-centered response. If globally, 85% of women, and in South Africa, 95% of women are accessing treatment for HIV through prenatal care, are we reaching out to their households to make sure that all children in that household are tested, and if any of them are infected, they're linked into care? We're also saying if these children are ending up in TB clinics or malnutrition wards, are we testing all those children in those places where we know we're going to have a big yield of children living with HIV? So there has to be a mind shift, and we need to understand the demographics and where we are with the HIV response. All
right, Doctor, it's been a pleasure talking to you. Thank you so much for all that information. Certainly a pleasure talking to you. Thank you.